against heart failure, the new weapons in the armory. Heart failure is reaching alarming epidemic and pandemic proportions. And therefore, there is always an ongoing war against heart failure. Now, these are the older drugs which we have been using for several years. And these are the new approved drugs during the last couple of years, which also we have been using. And these are the new drugs which positive trials, which are pending approval, not yet approved. That is non-steroidal MRA, quinolone, omecamtiv mecarbil, and injectable semaglutide. Now, it's very important to remember that heart failure is a deadly disease. More people die because of heart failure than acute myocardial infarction. And unlike acute myocardial infarction, where we have a quick fix in the form of primary angioplasty to undo the process, no such quick fix exists for heart failure. And therefore, heart failure demands early focus and attention if you want to slow down the trajectory of heart failure. The most important thing regarding heart failure you have to realize is that the human myocyte is not endowed with an endogenous capacity for repair. So once dead, is dead forever, unlike liver and other organs. So heart failure once sets in runs a malignant progression with a very high morbidity and mortality. The 5-year mortality may be the tune of 50%. In diabetics, it may be to the tune of 85%. Although these numbers are going to be improved after pharmacological revolution in heart failure. Drug therapy, device therapy, no doubt blunts this malignant progression. They improve survival also, but does not arrest it. Therefore, the end result is dismal, and therefore, cell therapy emerged as a very, very exciting option, but after several years of research, we do not know is the end of the beginning or beginning of the end, and this is still evolving. And therefore, prevention of heart failure is the most important agenda and indeed possible. And the ACC has redesignated class stage A heart failure, risk for heart failure, and B as pre-heart failure. Now, when we look in the context of diabetes, unfortunately, heart failure in diabetics is frequent, forgotten, and fatal. And when we look at the pathophysiology of cardiovascular disease in diabetes, what do you find? 50% of deaths are attributed to heart failure. And heart failure in diabetics have peculiar feature. It predates the development of coronary artery disease. Despite control of risk factors, guideline recommendation range, heart failure and hospitalization for heart failure can occur in as much as 45% of the patients. And the earliest defect in diabetic heart is diastolic dysfunction and not systolic dysfunction of coronary artery disease. And 1 out of 4 diabetic patients have got diagnosed heart failure. And hospitalization for heart failure is the dominant scenario in diabetes, even compared to hospitalization for ACS. And we have already talked about the mortality as very high. Now, these are the various pathological mechanisms, and I'm not going to address them. You have to realize that heart failure is akin to a malignant disease. The mortality is high, like malignancy, it runs a malignant progression. Polypharmacy should be the rule, and both diseases are remission and relapse. And remission of heart failure should not be taken as freedom from heart failure. Heart failure is always there. Stable heart failure is a myth, because apoptosis continues unabated, and this you can get by persistent mild elevation of troponins. And a patient who has little symptoms can suddenly die because of sudden cardiac death. Sudden cardiac death is more common in mild heart failure, who may get admitted also for heart failure without any warning. And hospitalization for heart failure is a very distressing event in the natural history of heart failure, because every hospitalization, every rehospitalization, as you can see, takes the patient closer to death. So if somehow you can minimize hospitalization from heart failure, this is indeed a great achievement. And SGLT2 inhibitors are very important drugs for minimizing hospitalization. As you can see, they decrease hospitalization of heart failure across the spectrum, whatever may be the subset. Rather, decreasing hospitalization for heart failure is a signature effect of SGLT2 inhibitor. The benefit occurs very early, as you can see. The other dicta which has come into vogue is just like we have door to balloon time or door to device time, the new dicta for heart failure is door to GDMT time, which means how early you initiate all 4 guideline directed medical therapy, and door to maximum dose GDMT, means how early you reach the maximum tolerated dose. Because 1 out of 4 patients hospitalized for heart failure die or is re-hospitalized within 30 days, and 30-day mortality is 10. So if you want to minimize the morbidity and mortality of acute heart failure, you have to initiate all these therapies. As you can see in this chart, they can be initiated on day 1 to 4, maybe on day 1, and the green chart shows the multiple benefit. And all these 4 foundational drugs should be considered complementary to each other and not competitive. And the sequence of events has to be individualized. When we are treating heart failure, it is very important to remember that there is a close cross connect between heart failure and CKD. Worsening heart failure, worsen CKD, worsening CKD, worsen heart failure, and therefore the cardiorenal continuum should be treated as a whole, and never heart failure alone, never kidney failure alone. And don't forget, targeting kidney disease triggers benefit for heart failure. And these are several reasons why cardiologists, diabetologists must focus on kidneys if they are treating a patient of heart failure. Iron deficiency is also rampant in patients with heart failure in the Indian context. And don't be misled, your hemoglobin may be normal, yet you may have iron deficiency. So if you want to diagnose iron deficiency, ferritin less than 100 or T-set transfer saturation less than 20, irrespective of the hemoglobin levels. And these are the various trials which have been conducted in iron deficiency. Diagnosing iron deficiency is 1C and intravenous iron is 1A recommendation. And iron therapy, many people believe, should be the 5th pillar of heart failure. Now, the pharmacotherapy has undergone a great revolution. The 4 foundational drugs have kicked off a new era of drug revolution in heart failure. They are class 1 recommendation, they are guideline-directed medical therapy, they produce incremental benefit on top of each other, and they power to improve outcome. And if you look at the projected survival, you initiate it in an individual who is say 65 or 55, you can prolong the life by 6 months, 3 years. And suboptimal GDMT is a very important cause of increased mortality and morbidity in our country. The drug revolution in heart failure has created a new subset of heart failure with improved ejection fraction, which never existed before. We have never seen before this drug. And Armoury has shown exciting data. It transforms an ICD eligible patient into an ICD ineligible patient. Now this is an analysis, as you can see, of 613 patients. All were eligible for ICD ejection fraction less than 35 post-MI. Within a matter of 6 months, you can see 32% ejection fraction increased to more than 35. Within a matter of 1 year, almost 61% the ejection fraction. So the message is optimize the use of Armoury before thinking ICD implantation in post-MI patient. And HFpEF no longer remains an orphan disease. Prior to 2021, HFpEF was considered an orphan disease, and HFpEF is more common in diabetes compared to non. Several trials were conducted, but all trials failed to show improvement. But now we have trials with SGLT2 inhibitors. You can see the Emperor Preserve, they deliver. Both have shown outcome results. And SGLT2 at the moment is a class 1 recommendation for HFpEF. Armoury is 2B and steroidal MRA is 2B. But and then all comorbidities must be treated class 1 recommendation because HFpEF is a disease of comorbidities. And the new drugs which are waiting approval are the non-steroidal amyloidosis and injectable semaglutide for the obese phenotype of HFpEF. And we published an editorial in JAPI, Drug Revolution in Heart Failure, a big step towards improving outcomes. Now, when we want to evaluate diastolic dysfunction or HFpEF, it is very tricky, and these are the various parameters we use, but time does not permit to discuss them in detail. Now, this is the new development in HFpEF. The FINE-ART trial with phenylalanine has shown positive results. You can see the primary outcome was positive. 13% reduction and a significant p-value, that is heart failure events and CV death. So this drug is likely to be approved in future. This is again the primary endpoint depicting same total worsening heart failure decrease, significant first worsening heart failure death also improved by 16%. death was not statistically significant. And several other trials with non-steroidal MRAs are going, so in future you would like to get more data besides the fine arts trial. Obese phenotype of heart failure is not uncommon in diabetes. Obese have PEP, and we have two positive trials, the STEP and PEP, which showed improvement in the quality of life and body weight, the primary endpoint. Also showed improvement in the 6-minute walk test. Also showed improvement in C-reactive protein, and this was carried out as STEP diabetes trial. In diabetic patient, again showed same thing. The primary endpoint of KCCQ improved significantly, weight improved significantly, 6-minute walk test improved, NT-proBNP decreased significantly, and time to first attempt, and also the inflammatory markers. And this is a pooled analysis of both these HFpEF trials, and you can see time to first attempt event, or so you get statistically significant improvement, so also the quality of life and the body weight. So the big emerging question is, will injectable semaglutide be classified as a heart failure drug for the obese phenotype? Only for the obese phenotype, possibly yes, in times to come. The drug revolution has also postponed device therapy in heart failure. Nobody could put a CRT or IC unless you have utilized all the 4 foundation drugs to their maximum ability. So less CRT are being implanted, less ICD are being implanted, less cardiac transplantation, less LVAD and so on. And SGLT2 inhibitor, the unique thing is they can be used across the spectrum of heart failure, irrespective of the ejection fraction. If you look at the beta blockers, up to 40% they are effective. If you look at Armoury, 55, 56, MRA 55, but SGLT2 inhibitor, the diagnosed heart failure, you can put them without going into any further investigation. They are a prevention for heart failure, they are a boon for CKD, and SGLT2 inhibitors has completed the whole circle. You can see trials in primary prevention, secondary prevention, HFpEF, KDACON2024, and they also slow down the trajectory of CKD, postpone dialysis for 10 to 15 years. This is HFpEF trials on the top, DAPA-HF and Emperor, and below you can see the Emperor preservative, where all are positive trials, and they also improve the quality of life. How SGLT2 acts, there are multiple mechanisms, I am not going to discuss them. They also slow down the trajectory of CKD by apparent arterial constriction and decreasing intervallar pressure. And the unique action is they decrease interstitial edema. They can be used across the cardiorenal continuum, and this is, you can see data from the KDACON2024 postponed dialysis after 15 years. Vaccination is also mandatory in heart failure, influenza and pneumococcal, but both of them decrease morbidity and mortality. The biggest problem in heart failure is adherence, and there are multiple reasons, as you can see, which must be addressed. Patient must be made to adhere to therapy. And in diabetics, as you can see, SGLT2 is a class 1, metformin 2AC, GLP1 neutral effect, DPP4 neutral effect, but sexual lectin can increase hospitalization for heart failure. Insulin is 2BC. TZP is contraindicated, and sexagliptin is also contraindicated. Verapamil is a new blockbuster for heart failure, specifically for worsening heart failure, because it directly stimulates the soluble guanylate cyclase. When your level of soluble guanylate increases, it provides protection to the vascular system, to the heart and the kidney. And this was the trial on the basis of which it was approved. The Victoria trial, you can see a 10% reduction is statistically significant in the primary endpoint of cardiovascular death, percentage of hospitalization. Look at the NNT, only 24. Galactic was carried out, but this is still awaiting approval of captain McCarmel, and research continues in heart failure. Several other targets are being explored, as you can see on the slide. So in summary, heart failure runs a malignant progression, and yes, we must always understand all therapies should be escalated to target dose unless side effects prove their use. De-escalation should never be attempted, because heart failure is never stable and potentially dangerous. We must follow the oncologist of polypharmacy. The 4 foundational drugs for HFpEF should be utilized for all as they provide incremental benefit on top of it. You use A, use B, more benefit, you use C, more benefit, D, more benefit. The door to maximum dose DDMT time should be achieved at the earliest within 1 to 4 weeks. The physician inertia should be minimized with the rampant and patient motivated for long-term polypharmacy to improve survival. The 4 foundational drugs are poised to postpone device therapy and cardiac transplantation, and HFpEF no longer remains an orphan disease. Emperor preserved delivered trials with EMPA and DAPA for involvement, improvement in outcome of HFpEF and are given class 1 recommendation. In heart failure, the whole cardiorenal continuum should be targeted, never heart failure alone or never kidney failure alone. Velocibet is approved for worsening heart rate, but Mecarbal is awaiting approval in HFpEF. Non-steroidal MRA is awaiting approval in mid-range and HFpEF, and semaglutide awaiting approval phenotype of HFpEF. NIV therapy must be utilized in patients with iron deficiency. Vaccination is mandatory, and prevention of heart failure is the most important agenda, because human myocyte is not endowed with the greatest capacity for repair. Once dead, is dead forever. That you should never forget while you live. Thank you very much for your kind attention. The weight improved significantly. 6-minute walk test improved. Anti-proBNP decreased significantly, and time to first attempt, and also the inflammatory markers. And this is a pooled analysis of both these HFpEF trials, and you can see time to first event, or so you get statistically significant improvement, so also the quality of life and the body weight. So the big emerging question is, will injectable semaglutide be classified as a heart failure drug for the obese phenotype? Only for the obese phenotype, possibly yes, in times to come. The drug revolution has also postponed device therapy in heart failure. Nobody could put a CRT or IC unless you have utilized all the 4 foundation drugs to their maximum degree. So less CRT are being implanted, less ICD are being implanted, less cardiac transplantation, less LVAD and so on. And SGLT2 inhibitor, the unique thing is they can be used across the spectrum of heart failure, irrespective of the ejection fraction. You look at the beta blockers, up to 40% they are effective. You look at Armoury, 55, 56, MRA 55, but SGLT2 inhibitor, if diagnosed heart failure, you can put them without going into any further investigation. They are a panacea for heart failure, they are a boon for CKD, and SGLT2 inhibitors has completed the whole circle. You can see trials in primary prevention, secondary prevention, HFpEF, ADHF, and they also slow down the trajectory of CKD, postpone dialysis for 10 to 15 years. This is HFpEF trials on the top, DAPA, and Emperor, and below you can see the Emperor preserved deliver. All are positive trials, and they also improve the quality of life. How SGLT2 acts, there are multiple mechanisms, I am not going to discuss them. They also slow down the trajectory of CKD by apparent arterial pulsation and decreasing intercoronary pressure. And the unique action is they decrease interstitial edema. They can be used across the cardiorenal continuum, and this is, you can see data from the KDACON postponed dialysis after 15 years. Vaccination is also mandatory in heart failure, influenza and pneumococcal, because both of them decrease morbidity and mortality. The biggest problem in heart failure is adherence, and the multiple reasons, as you can see, which must be addressed. Patient must be made to adhere to therapy. And in diabetics, as you can see, SGLT2 is a class 1, metformin 2 is C, GLP1 neutral effect, DPP4 neutral effect, but sex-selected can reduce hospitalization for heart failure. Insulin is 2BC. TZP is contraindicated, and sex-selected is also contraindicated. Velocibet is a new blockbuster for heart failure, specifically for worsening heart failure, because it directly stimulates the soluble guanylate cyclase. When your level of soluble guanylate increases, it provides protection to the vascular system, to the heart and the kidney. And this was the trial on the basis of which it was approved. The Victoria trial, you can see a 10% reduction is statistically significant in the primary endpoint of cardiovascular death, percentage of hospitalization. Look at the NNT, only 24. Galactic was carried out, but this is still awaiting approval of Captain Mecarbal, and research continues in heart failure. Several other targets are being explored, as you can see on the slide. So in summary, heart failure runs a malignant progression. Yes, we must always understand all therapies should be escalated to target dose unless side effects include their use. De-escalation should never be attempted, because heart failure is never stable and potentially dangerous. We must follow the oncologist of polypharmacy. The 4 foundational drugs for HFpEF should be utilized for all as they provide incremental benefit of carbohydrate. You use A, use B, more benefit, you use C, more benefit, D, more benefit. The door to maximum dose DDMT time should be achieved at the earliest within 1 to 4 weeks. The physician initiative should be minimized with is rampant and patient motivated for long-term polypharmacy to improve survival. The core foundation does a poised to postpone device therapy and even cardiac transplantation and HFpEF no longer remains an orphan disease. Emperor preserved delivered trials with EPA and DAPA shown involvement, improvement in outcome of HFpEF and are given class 1 recommendation. In heart failure, the whole cardiorenal continuum should be targeted, never heart failure alone or never kidney failure alone. Velcivate is approved for worsening heart rate, but Mecarbal is awaiting approval in HFpEF. Non-steroidal MRA is awaiting approval in weight range and HFpEF, and semaglutide awaiting approval phenotype of HFpEF. NIV therapy must be utilized in patients with iron deficiency. Vaccination is mandatory, and prevention of heart failure is the most important agenda because human myocyte is not endowed with ambiguous capacity for repair. Once dead, is dead forever. That you should never forget while you live. Thank you very much for your time.
Plum, sir.